Good morning, everyone. Welcome to the 6th Annual Spotlight in Breastfeeding Research from very snowy Northern Ireland. I'm Professor Marlene Sinclair from the University of Ulster, and I'm hosting the session this morning. We're going to be running from 9 o'clock until 12 o'clock, just in case you've got little children and you need to make any arrangements. And we'll be having a very short tea break just before lunch, but just before 11. So welcome to you. Good morning, good afternoon, good evening to all of you. I realize that we have almost 400 participants who are joining us this morning, and it may take a little bit of time for people to make the connection. So I just need a slide to say welcome to you from wherever you are in the world. Leah, who's working behind the scenes along with Adam from the Institute of Public Health, has sent me information about some of the countries that you are joining us from. So we're absolutely delighted about it. I mean, it's wonderful to share the research that's going on in Northern Ireland with you, because this is about it. This is a spotlight on breastfeeding research, and it is just that, a spotlight on a little tiny corner of the earth. But it's very important for us. It's a precious little place where we've been doing breastfeeding research now for over 20 years. And this is our 6th annual Spotlight in Breastfeeding Research. So, you know, this is the 6th time that we've been trying to reach out and let people know what's going on in this little space. So I really hope you're going to enjoy today's presentation. And those of you who are from Turkey, from the US, from Canada, from Great Britain, from the Netherlands, I mean, we are just so delighted to have all of you join us, and really hope that wherever you're at, it's not too snowy, or some of you might be in very hot places, and lucky for you. Anyway, I just want to say at the very beginning of this event, it's very important that I acknowledge and thank our sponsors and supporters and the core team working behind the scenes today, just in case any of them sneak away before the end. And I'd like to thank Dr. Joanna Perley from the Institute of Public Health, Dr. Nicola Armstrong from the HSC R&D Office, Dr. Anita Yakundai from the Northern Ireland Public Health Research Network, Joanna Savage from the Institute of Nursing and Health Research at Ulster, Marissa Fagan, Leah Friend, and Adam McCune at the IPH. They're the folks working behind the scenes right now as we're running this event. So just to tell you a little tiny bit about the Doctoral Midwifery Research Society, because that's what this event is being run under, the umbrella that is being run under. Particularly, this is important for those of you who are joining us for the very first time. This annual Spotlight in Breastfeeding Research is delivered within the portfolio of the Doctoral Midwifery Research Society, and that was established in 2007 with funding from the R&D Office, and we were delighted to get that start. You can find the DMRS on YouTube, Twitter, and Facebook, and you can. The website has some really useful resources. We have blogs on breastfeeding, and we have blogs on bullying, and there are some really useful teaching videos. There are some fantastic presentations that you can log on and you can access them for free. Excellent videos. They really are on all sorts of issues, all sorts of birthing issues, and the events, the breastfeeding conferences that we've been running, or the spotlights on breastfeeding research. Most of the presentations for them are actually available from the DMRS website. So I would strongly advise you to have a little look at them, because they are really valuable, you know, they're free. Not much is free these days. But anyway, we are interdisciplinary and international, and we really do try very hard to involve members of the public, consumer groups. We try very hard, and you will see we have like a template for the way in which we run these spotlights, and they all have the same sort of pattern. We have, I usually say a few words at the beginning about what we're about, and then what we normally have then is presentation from either the R&D Office or the Institute of Public Health. We want to hear a little bit about breastfeeding policy and practice and research. And then we have pre-doctoral presentations from our PhD students. And then if some of them are available, we'll have some of their postdoctoral presentations. Then we always have a really, really important event, which is a special lecture given by a person who's eminent in the field, somebody who has exceptional research knowledge and who can share information with us. And today we had Professor Tina Lavender doing that. So we're delighted to have her. She'll be doing our keynote for us. And we try to finish and keeping the whole situation, keeping everything very real by going back to the people for whom the research really has meaning. And that's the mothers who are at home with the little babies. So our last speaker today will be Dr. Mary Jane McCluggage, and Mary Jane will be sharing her breastfeeding journey with you. So that's sort of just a little bit of a rapid review or a rapid overview of some of what's about to happen to you this morning in terms of listening. And our pre-doctoral students have fantastic research to share with you. So in terms of just making it quite sure that the whole purpose of this event is to share freely evidence from breastfeeding research. And as I said to you, from our little corner of the world, Northern Ireland, our little corner, we're sharing what we're doing over here with you. And we, in terms of our DMRS website, we have many resources, and this particular webinar that we're running today, we're delighted to have the support of the Institute of Public Health. That's for the first time, so we're delighted to have your help, Joanna. I just have one or two tiny points that I want to make. And this is a dissemination event where we're trying to share with you the research that we're doing. Dissemination of research, it's probably, you know, something that we all think we know everything about it, but the most important thing is to say to you that it's of no use to anybody unless it actually gets to the people who need to hear it. And that's why in this type of event, we try to make it free. We try to put it up and make it accessible afterwards. And we try to involve people that we know who have been involved in doing research that we can stand over, that the rigor of the research is transparent, that we can verify and have confidence in the data that they're presenting. So you need to be assured that in terms of what you're about to hear, that it has been sifted through, that it's been verified. And that's very, very important, because when you're disseminating research, that's important that the research you disseminate is rigorous. But again, it has to be given to you in a manner in which you can understand it as well. So research that's effective, it's not simply getting the findings of research to the people who can make use of them to maximize the benefits of the research without any delay. That's what the NIHR tell us. And it is a planned process. And it has to be, and you have to do that kind of research working with your partners, with the members of the public that you've been engaged with during the research in terms of developing the research. It's very, very important that we do that. And we also need to make sure that we communicate and we interact with wider policy and health services audiences. And again, if you look at the programme, you'll see that that's why it's important that we're working with the Institute of Public Health. We're working with the Northern Ireland Health and Research, Public Health Research Network. So we know we're working with members of the public. The benefits of doing really good disseminated research will be that, we actually build the research evidence base for policy, practice and education to come. We're building a future. And that means that we can have a journey that leads to meaningful outcomes. We can build research that has impact. We can do research that's actually going to be of benefit to women. It's going to be of benefit to the public. It's going to be of benefit to the health professionals. It's going to be of benefit to policymakers. We can also help to promote and support organisations and build networks. We can raise the profiling. We can share knowledge. Now, dissemination is a key. And if you have knowledge, let others light their candles in it. That's what this is about. If you've got knowledge and you've been doing something really good, share it with others, share it freely, and believe in it. And the light will move, the light will grow, the light will remain. And this is our 6th annual Spotlight on Breastfeeding Research. I hope we've all had a little opportunity to look at the programme. I've given you a brief introduction to it. I really do hope that you enjoy it, that you have a wonderful day, that you hear something that you've never heard before, and that you stay with us. Thank you very much. Now, I'd like to hand you over to our first speaker. Our first speaker today is Dr. Joanna Perley. Joanna is the Development Officer, Public Health Development Officer at the Institute of Public Health. Over to you, Joanna.
Thank you, Marlene. Good morning, everyone, and welcome to the conference. It's a delight to be able to say a few words here today. And thank you, Marlene, for the introduction. Just to say a little bit about myself and about the Institute. The work of the Institute is very much focused on promoting health and well-being, improving health equity, and reducing health inequalities. And we do this through evidence review. We do this through policy review and evaluation, and through various forms of research as well. Just to say a little bit about myself, I'm Public Health Development Officer with the Institute, and I work across a number of policy areas, obviously breastfeeding being one of those, but as well as that, I work in the areas of alcohol policy, tobacco control, and gambling as well. And in addition to that, I've also a remit for health impact assessment. So as I said, it is a pleasure to say a few words at the start of the conference today. I'm not going to speak for very long, really sort of 5 or 7 minutes or so, but in that time, I would like to highlight for you some of the breastfeeding research and policy developments that are taking place in Ireland and Northern Ireland. So really just starting on home territory, so to speak, I just want to make mention of probably one of the closest pieces of work that I've been involved in terms of breastfeeding policy and breastfeeding research, and that's the breastfeeding research work strand. This is one of 7 work strands which support the implementation of the breastfeeding strategy in Northern Ireland. The work strand has been chaired by my colleague, Dr. Nicola Armstrong, who's Programme Manager in the R&D Division of the Public Health Agency, and I've supported Nicola as interim chair since September 2021. The group meets twice a year and we report to the Breastfeeding Strategy Implementation Steering Group. The work strand has 3 actions as part of its commitments within the overall strategy. We review research evidence and information on effective practice. We influence new and ongoing research and build an understanding of what works in terms of increasing breastfeeding rates in Northern Ireland. And we do this by working with the Northern Ireland Public Health Research Network, the PhD programmes and the DMRS. And we support breastfeeding research partnerships and explore opportunities for research collaborations. In June last year, we had an excellent presentation and a really insightful discussion around research opportunities with Hilary Campbell and Anne McRae from the Human Milk Bank. The research work strand also shares insights on published and ongoing research. We will review international evidence, and a few years ago, we collectively published a paper in a midwifery journal on breastfeeding initiation rates, interventions to increase breastfeeding initiation. And we've also collaborated or submitted research applications as part of collaborations in the past as well. The group has supported the planning and organisation of today's conference, and I'm not going to talk specifically about the research that's underway in Northern Ireland because you're going to hear about that over the course of the morning. So I'm not going to steal anyone's thunder by talking about their work before they get a chance to do so. I just want to briefly mention the breastfeeding strategy for Northern Ireland. Our strategy is reaching the end of its 10-year term, and the department is currently undertaking a review of the strategy with support from the Institute of Public Health, the Public Health Agency, and members of the Breastfeeding Strategy Implementation Steering Group. As part of the review, the Institute hosted and facilitated a knowledge needs assessment workshop in October 2022, and some of you who are at the conference today may well have participated in that workshop last year. At that event, we considered the knowledge and evidence gaps and identified the research priorities for breastfeeding in Northern Ireland. And the findings from that will feed into the overall departmental review of the strategy. Moving across the border then to Ireland, my colleague Laura McHugh, who is the National Breastfeeding Coordinator in the Health Service Executive, has very kindly shared some updates on work that's happening in Ireland and has agreed for me to share these today. But just a couple of pieces that I think will be of interest to the audience here today. In May 2022, the HSE published new national standards for infant feeding in maternity services as part of the Baby Friendly initiative. They have appointed over 30 new infant feeding posts to provide specialist lactation support in maternity and community services. And they're currently piloting a national infant feeding education programme for midwives and public health nurses. In terms of breastfeeding research in Ireland, I'm just going to highlight a few studies for you. I'm sure this doesn't encapsulate all of what's going on. I apologise if there's key work that I've missed, but just to highlight a couple for you. Firstly, a study being undertaken by University College Cork and funded by the Health Research Board is looking at practice enhancement for an exclusive breastfeeding across the pregnant woman's perinatal journey. Another study that's currently underway is a collaboration between University College Dublin, the Health Service Executive, and under the auspices of the National Healthy Childhood Programme to explore breastfeeding knowledge, attitudes and practices of GPs and practice nurses in the Dublin area. The findings of this research will help inform future developments in infant feeding education and training programmes. And finally, just to mention for you, one of the Shared Island funded research studies. This is a piece of work that is looking at emergency preparedness for infant and young child feeding. As I say, it's been funded by the Shared Island unit and is currently being undertaken by researchers at Technological University Dublin and Queen's University Belfast. Finally, just a couple of pieces which fall outside of the sort of more traditional breastfeeding research interest, so to speak, but I think you'll find them of interest and of relevance as well. And that's to say to you that in Ireland, the Online Safety and Media Regulation Act, which came into effect in December last year, includes a provision which prohibits or restricts commercial communications, in other words, advertising, of foods or beverages considered to be of public concern in respect of the public health of children. And they specifically name infant formula, follow-on milk, and foods that are high in fat, salt and sugar within that legislation. So that's a really important move forward in terms of the online regulation of infant formula advertising. And secondly, just to make you aware that the Health Service Executive launched its first national maternity bereavement experience survey in September of last year. This was an online survey and it asked women and their partners about the bereavement care they received in an Irish maternity hospital or unit following pregnancy loss or perinatal death. And the aim of this survey is to learn from the experiences of bereaved parents and find out what's working well and what could be improved. Again, these are just slightly aside items, but I think they're also of interest and relevance to the audience here today. So just finally, thank you for your time and your attention this morning. We're delighted that so many of you have been able to join us online again this year. And I know we have a very informative and inspiring morning ahead. And I'd just like to say a special word of thanks to Marlene. She's been thanking everyone this morning, but I would like to thank her for all her hard work in making today possible as well. So enjoy the conference. Thank you.
Thank you very much, Joanne. Lovely. And I mean, I must say to you, I'm absolutely delighted to hear the Online Safety and Media Regulation Act. It's great news. It's taken a long time to get there. So thank you very much for sharing the research developments in the island of Ireland. It's lovely to see it's lovely to see the shared island of Ireland developmental work and research. So that's great news. Thank you very much. Now, folks, I want to tell you about our next speaker. Our next speaker is Adele Payton, and Adele lives in Fermanagh, and Adele is one of our a really unbelievable person. She set up the Breastfeeding Northern Ireland network, and she's a parent of 3 kids. She's now an IBLC lactation consultant. I mean, she's just unbelievable. She's wonderful. She's made a video for us this morning. It's a really high quality video and you will actually enjoy it. And she's going to tell you all about the Breastfeeding Northern Ireland network. I mean, there's nearly 14,000 members in it now. I mean, I can remember when we first talked to Adele, you know, a couple of thousand, and it's just grown enormously. And the other thing to tell you about Adele is Adele's Breastfeeding Northern Ireland network has supported research for several of our PhD students across Northern Ireland. I'm not sure about the island of Ireland, but I know that certainly in terms of the work that's been done by ourselves in Ulster and in Queen's University, because we need 2 universities in Ireland, in Northern Ireland, for those of you who don't know the geography. But we've only 2 institutions offering academic education and research, and that's Queen's University in Belfast and Ulster University. But anyway, having said all of that, please sit back and enjoy Adele's presentation.
Hello everybody, you're very welcome and good morning. My name is Adele Payton and I am the founder of the closed Facebook group Breastfeeding in Northern Ireland, or BFNI as we call it for short. So I'm just going to share my screen with you here so you can see my slides. So here are just a few photographs of the mums from the group who, as you can see, just sharing their lives out and about and breastfeeding everywhere out and about in Northern Ireland and beyond. So I created the group back in April 2013, and I created it because I was in another group. And sometimes when people asked about information from the north, maybe where a group was or where they could get a good nursing bra, they couldn't find the information. And I thought, oh, there's a wealth of information here we can share with each other. So initially there was a lot of peer support mums in the group from all over Northern Ireland, and so the information within the group was very good from the beginning, and we now have 14 admin, and you can see a wee picture of some of us here on a Zoom during lockdown. So now we have almost 14,000 members, which is amazing, and it's just great to have everybody together in one space. So what do we do? What happens? Why is Breastfeeding Northern Ireland group useful and good? So as an admin team, we are focused on listening to mothers. We empathise and we accept how they're feeling, and we avoid trying to fix things. We're really more about giving information and then offering support as the mums make their own decisions with the information that they've been given. And we also provide that's kind of help and support just to meet the goals that the mums have for their breastfeeding journey. We do have specific values within the group that we endeavour to uphold, and that's really that breastfeeding is the normal way to feed babies, and that we give breastfeeding answers to the queries that arise. We support the World Health Guidelines, and we also added in there that we believe in being responsive to babies and also respecting children as we guide them as parents. And the members here offer peer support, so it's a peer support group, and people are encouraged to contact their healthcare professional or one of the breastfeeding helplines if they need more support. So I just took a wee snapshot of 24 hours within the group, part of this is broken down into weeks and months, and then I'll go on to look at the 24 hours. So in the last month, there have been just under 300 posts. On the last week, 78 posts. And just as an idea, the people commenting on that, there was about 592 comments. So around about 11 posts a day, and every post would receive a comment. We would keep an eye on that everyone gets an answer of some kind, but some of them would have more and some less, but averaging around 7 comments each. And we can also tell within the group how many people have been active that week. So last week there were 7,605, just kind of crudely around about half of the group members were, or a bit more than half of them have been active. So that's just saying like 55% of our overall membership were engaging with each other in that week alone. And we continue to receive new member requests. So we had 47 last week. So this is where I was talking about in the 24 hours that I looked at, there were 13 posts, and 10 of those were requests for breastfeeding help. And of those 10 requests for help, 7 were answered by an admin. So the other 3 would have been answered by mums within the group, so mum-to-mum support, that admin felt that the post had been adequately answered and supported, that we didn't need to add to that. So sometimes people wonder about the kinds of things that are being shared or questioned in the group. So you can see here, there's a whole range of things from my older baby's feeding a bit less, do I need to pump to protect my supply? My 13-day-old baby, I'm worried they have reflux. My baby's in hospital, can I get some help with pumping, or how often do I pump, or it's not working, or that kind of thing. Sleep is always a big one, and a 14-month-old, they're not sure, they've stopped feeding, is it a nursing strike or have they self-weaned? Someone else was giving away some free breastfeeding things, someone wondering how much milk to leave when they were away for the day, someone wondering if it's normal how often their 14-week-old feeds. Someone else asking about the COVID vaccine, is it safe? A really common one is help with low weight gain. And a lovely breastfeeding print someone got to celebrate their journey, and then an admin info post on switch nursing and breast compressions. And finally, at 10 someone asked about HRT and breastfeeding, and if anyone had experience with that. So a really wide and varied kind of range of things. So along with the public group, with the private group as well, we did start a public page back in January 2018. And we did that because we felt, and the feedback from mums was that it was brilliant being in this little kind of bubble together, but that the wider society, just their information on the realities of breastfeeding and the benefits, or what breastfeeding does for us and our babies, wasn't really out there as such. So our idea behind the page was really to get more information out there to the general public and normalise breastfeeding. And it allows the mums within the group to share information that might only normally be seen in the group. So maybe information posts on, for example, like how immunity works within breastfeeding, or how it feeds the baby's gut and why that's helpful, and things like that. So this October, then, we have 8,760 people following the page. So really good support for that and good information going out there. Back in 2018, we received awards for our group. That was the Mama Awards in Glasgow. Sorry, and also Carol Smith, who is a lactation consultant who's been in the group since the very beginning, before she had done her lactation consultancy training, and was a breastfeeding counsellor, and gives very good clinical information within the group as well, where needed, and very good support. We also have Wendy Jones in the group, who is the specialist, of course, for the breastfeeding and medication. Wendy will, if tagged, respond to mums individually as well for specific cases, which is just fantastic, and we're indebted to have her support. So I just did a little survey there in October, which we do most years, to see how the group is going. So 95% of the mums within the group felt that BFNI had been a support to them on their breastfeeding journey, which is great. And of the 5% of people who said that it wasn't specifically a support, the kinds of things that they've said were that they found the group too late, so it wasn't a specific support to them, but they've learned a lot, and that's helped them to support others, which is amazing to hear. And this second response here was that I don't actively partake in discussions, so I don't, it hasn't specifically been a support to me one-to-one. However, I've searched for many topics and keep up to date with the posts for information. So there's a search facility within Facebook groups, and on there mums can search, for example, for cracked nipples or mastitis, and they'll see previous posts and previous information that will have come up. So these are just I just put up a wee range of the ways that people responded to say that they found it helpful. What were the kind of things? So evidence-based information, support and encouragement, reassurance, extending their journey, availability, helpful, feeling part of a community, good response rate, understanding normal baby behaviour is a huge one for mums, particularly in the early weeks, and just education about breastfeeding. So what has happened over the years then? So it's been 9.5 years now the group has been running, and what has happened is that the mothers that we now have in the group have a wealth of information and experience. So you can see here just a few of the things that mums will have breastfed through, and these are not your kind of normal course of breastfeeding. So this would be now we had, sorry, I forgot to say at the start, we had a response here. I just collected 120 responses because I could have been there all week analysing data, but of the 120 responses, these are the actual numbers of people who responded with these experiences. So it's around about 7 people there tandem fed, where they feed 2 kids at once. And a child that weaned in pregnancy. So people feeding up until and through some of their pregnancy, over 30. And again, people who fed right on through the pregnancy and beyond is there around 27. There's also people who are feeding twins. One mum amazingly who's fed triplets, and a number of mums who have fed children with additional needs. And this is where the group again comes into its own. I was involved in supporting a mum through my work in Sure Start, where I work as a breastfeeding support worker and a family support worker. I was involved in supporting a mum who has a baby with a health condition, and she knew before the baby was born that the baby would have this. She came to me for some support with getting breastfeeding or getting pumping off to a good start. And she said, no, it's really, really rare. You've probably never heard of it. And I said, I actually have. And I know a mum who's breastfed, who's done what you're hoping to do, pump and then get the baby to the breast after a few weeks and go on to breastfeed. So I was able to get in touch with the previous mum from our group, ask her if she would consent to this other mum contacting her. And the 2 mums are in contact now and supporting each other. And it's just amazing to be able to do that. So there's just a huge wealth of experience and knowledge within the group, which is just absolutely fantastic. So I always think it's interesting to look at the age of the current nurslings as well, to get an idea of what kind of demographic we have in the group, really. So what is highlighted to me here is that we don't have a huge number of members in those early weeks, well, of the 120, if assuming they're reflective of the rest of the group. So those mums, or maybe they didn't respond because they're in the thick of those early days, not sure, but it wasn't coming up anyway that those mums were so active, the mums in the babies under 12 weeks. So we know that's when breastfeeding, there's a huge drop off in our breastfeeding rates here in the north, and it's a problem, I suppose, in lots of countries, is the early drop-off rates. So, and it came up in the feedback as well that mums said they'd found the group quite late, and they wished they'd found it earlier and that they'd known about it antenatally. So it's maybe it's something that we need to maybe work on, that getting the word out there earlier. But what we do have is a fabulous engagement there from those mums who have children from 12 weeks right up to 4 years and beyond. And what is creeping up is the duration of breastfeeding, and we see that reflected in our stats here in Northern Ireland as well. So that's absolutely amazing. And like those mums who have fed through all the challenges and gone on to feed a child into toddlerhood and into childhood, really has a wealth of knowledge and experience, and very often a major passion for breastfeeding, and it becomes an integral part of their mothering. And it we know it changes brains as well as bodies, and changes and when I mean brains, I'm not referring to the academic markers that are increased, but more so the nurturing, the loving, those responsive relationships. So there were a few suggestions from improvement, face-to-face support, and finding out about the group earlier, as I had mentioned, and maybe some Q&As. So we'll sort that. We do support research. We are a bit like gatekeepers of the group, in that we don't want it to become overwhelming for mums with lots and lots of surveys. So we are quite picky about letting people use the group for research. But we have had some notable ones. So Sharon Gale on nipple pain was one, and Professor Sinclair on the traumatic memories of breastfeeding, used some of the experiences of the mums within the group very sensitively. And then again in the Connect people with Dr. Julie McCullough, again some of the experiences within the group were helpful for them in their own Facebook group that they had set up as well. And then more recently, Mary Jo Chesnell on the experiences of the breastfeeding support providers. Yeah, and there were lots of smaller ones as well that I didn't keep note of. So there are other ones in there as well. But if anybody is interested, then give me a shout and we can work something out generally. But we, as I say, we try and keep it to a minimum. Just want to share before I finish up some lovely feedback that we have from within the group, and so I'm trying to get my little face out of the way here so you can see it. So just saying it's an amazing group, and I'm so glad to have met my milestones, and they couldn't have made it without the group, and how good it was for their confidence. And that's me. So I hope you all have a fantastic day. Thanks a million for listening. Bye.
Wow, wasn't that spectacular? Wow. Unfortunately, Adele isn't here with us this morning. As you can see, she's extremely busy. But I'm not joking. I mean, she's been so helpful to all of us. I mean, she's her support it's amazing. But it's just so lovely when you just look at the history and how this happened. I mean, an ordinary mother, you know. And just look at how this has grown. I mean, that's why it's a pleasure to be able to put the spotlight on people like that, and the networking, the love and the care, the support. I mean, it's amazing person, wonderful supporting group. So I'm absolutely delighted, and I'm so thankful that you're able, from whatever part of the world you're joining us today, to actually see, you know, our little corner here and what's been going on, and the amazing work of Adele and her team. So thank you, Adele. I'm sorry you're not here, and there's a question and answer, and I will see if we can send it to Adele afterwards, and if we can get a response back for you. So thank you very much. I'm now going to introduce you to our next speaker. And before I do, in Adele's presentation, Adele has said that she'd helped me with research into women's traumatic breastfeeding experiences. And it was that research, it was that support that she gave me that helped me to write the brief for the very next research student that you're going to hear sharing her research, and that amazing work that she has done to try to number one, identify and categorize and classify and help women who actually have had traumatic breastfeeding experiences. So I'm going to introduce you to a PhD student now. That's her first one this morning, and her name is Rachel Black. And Rachel is a mum, and Rachel has an MSc in health psychology. Rachel is a PhD student funded from the DFE, from our department here in Northern Ireland. And Rachel is a student in the Maternal, Fetal and Infant Research Centre at Ulster. So over to you, Rachel and Joy, and thank you very much.
Thank you so much, Marlene. Okay, hopefully that's sharing for everybody. Yes, good morning. Today I'm going to present my findings from my PhD research, which looked at developing an online group EMDR intervention for breastfeeding trauma recovery. So when women have negative breastfeeding experiences, it can really impact on their confidence and can leave them with sometimes actually a fear of breastfeeding, which can result in them less likely to breastfeed any future children. Now, previous research has found that the impact can be so profound that they go as far as saying that they've been traumatized. It leaves them with feelings of failure, like they're a bad mother, and you know, this can really impact on their mental health, and it can also have an impact on their bond with their child as well. So part of my PhD actually involved conducting a psychometric study to validate a questionnaire, which is called the Existential Breastfeeding Difficulties Questionnaire. What I looked to do was to use that as a tool for actually identifying women who had breastfeeding trauma. And one of the findings that came out of that study was that out of that sample of women that completed the survey, 7% of those women were above the threshold for PTSD. So what that really showed me was that, you know, breastfeeding trauma is real, and it's important to research this further. Particularly because when you look at the literature, you know, we know that breastfeeding trauma is real now, but there's no research out there on any interventions that are specifically designed to help women heal from this trauma. So there's no psychotherapy interventions that have been researched to see if they're effective. And that was why I then aimed to explore the feasibility and acceptability of an online group EMDR intervention for incorporating a social media component for reducing breastfeeding trauma. The intervention was utilised the group traumatic episode protocol, which is a group protocol for EMDR within a group format. We conducted it online via Zoom, and each woman completed 3 sessions. So the sessions had 2 EMDR clinicians facilitating it. One was facilitating the actually guiding the women through the therapy, and one was acting as a support therapist who was there for just ensuring their psychological safety and that everyone was okay during the sessions. There was a Facebook group as part of the intervention, and it was monitored by the research team, and it was really there to connect women with each other and to provide access to Zoom links and information about the intervention. So it was a mixed methods design, and the first phase of that was the quasi-experimental time series design, which had 4 time points. And for that, I used purposive sampling to recruit women who were aged between 18 and 49, who had scored 33 above on the X breasts, which indicated that they were experiencing breastfeeding trauma. They were recruited online using social media platforms of community organisations which were working in breastfeeding and perinatal mental health, and also through my own research networks. The outcomes that I explored were women's breastfeeding PTSD scores, so any reduction in score, also breastfeeding self-efficacy, whether there was any change in breastfeeding self-efficacy. I also looked at subjective units of distress, and that's termed their SUD scores, and also any future breastfeeding intention to see if after the intervention they would breastfeed again. The second phase then involved a qualitative focus group, and that was really just to sort of evaluate the interventions, get the participants' experience of the intervention. And with that, we explored their experience of the EMDR, how they found the online delivery of the intervention, what their experiences were of the Facebook group, and also feelings that they had towards breastfeeding following the intervention. So we had 5 women that were eligible for the study with XPRESS scores between 36 to 54. So just bearing in mind there that anything above 33 would be above the threshold. So some of those are quite high scores for people who are experiencing breastfeeding trauma. We had 1 woman who was involved in the study who had a current diagnosis of depression, and 2 women were currently breastfeeding subsequent children at the time. The length of time varied with each woman in terms of their breastfeeding trauma experience. So 1 woman had breastfed for less than 24 hours, and 1 woman had breastfed for more than 12 months. So it really varied. The eldest child was 19 years old, which really for me demonstrates how, you know, the lasting impact that this has on women, that 19 years later, that trauma is still there. So just onto the sort of primary outcome finding of the breastfeeding PTSD scores. So we collected 4 different time points, and there were two data collections prior to the EMDR, the 3 EMDR sessions, and then 2 after the EMDR sessions. And all but one of the women saw reductions in breastfeeding PTSD scores, with scores ranging from a 4% decrease to a 32% decrease. We did see one woman who had an increase in score, but I think it's important to sort of note that this particular woman was actually being treated for depression at this time as well. And this may indicate that she was maybe a bit too far outside what we would call her window of tolerance. So in many ways, what this does is GTIP, it's a low, it can be seen as a low intensity intervention. So this might sort of indicate that it can be used as a triage for any participants who maybe might benefit from going on to full EMDR therapy. Also, just to note here as well, there were 2 women who missed 1 session each. And actually that first participant there, number 101, she missed a session. So she only got two sessions of EMDR, but she saw a 32% decrease in breastfeeding PTSD scores. And she's actually now scoring below the threshold for breastfeeding trauma. So those are really, really positive results. The women's subjective units of distress also showed a marked difference after taking part in the EMDR, with all participants showing considerable drops in scores. And you can see that even from just prior to the EMDR sessions to the T2 time point there, but also in the follow-up, we continued to see some improvement in scores there as well. The other outcome measures of breastfeeding self-efficacy, we saw 3 out of the 5 saw an increase in breastfeeding self-efficacy scores, which is a positive result. It shows that they're feeling more confident in their ability to breastfeed. Now, interestingly, the 2 women who didn't see an increase were the 2 women that were actually actively breastfeeding at the time. Now, this was a small scale feasibility study, so it'd be interesting to see if we upscaled this, whether those sort of findings would come through on a larger scale. In terms of future breastfeeding intention, then I asked the question at each time point throughout the study of whether they would breastfeed. If they were to have another baby, would they breastfeed again? 3 women absolutely throughout the whole thing said yes, they would definitely breastfeed again. But for the 2 other women, one had stated that she didn't know at the start of the study, and then following the intervention, that changed to yes. And for the other one, she started off with no response, and following the EMDR sessions, that changed to don't know. So that really indicates for me the potential for positive behavioural change as a result of EMDR. I also asked the question, would you recommend group online EMDR for friends and family? And all of the participants responded yes. So again, that really demonstrates the acceptability of the intervention for the participants. So then to the qualitative phase, there were 3 main themes that were generated from the data. And the first was that it heals memories. Following the EMDR, the participants sort of described how they had the negative thoughts of self-blame and failure were no longer the sort of default that they always went to. They were able to sort of view their whole experience in a more distanced way, and they were able to have a more balanced perspective with it. One of the participants had actually described how it had lost the memories, had sort of lost the ouch factor, which I think for me was really significant to see that, to sort of see that pain had left the memory for them. Then second theme to come through was that it provided personal support and a space for healing. So this really encompassed aspects of having access to the therapy in a safe and supportive space where they were able to work through their trauma. It discussed its practicalities in that it was cost effective, it was time saving, they were able to log on and fit it around family and work. We actually had one participant who joined us from a family holiday in our caravan. So it really was a great way for them to be able to work around family life. They also highlighted how with it being online, they were able to be in their own environment, and that enabled them to feel a bit more comfortable, and that they felt more sort of safe because they were in their own safe space, or their own comfort zone, which they felt was better for them in terms of not panicking and maybe being around people that you don't know in other sort of face-to-face environments. They also said that knowing that there were people on the call meant that they weren't in the spotlight as they might have been if they were doing individual face-to-face therapy. Sorry, the third thing was then advocating for social connections. Overall, the participants didn't use the Facebook group really for support. One participant suggested it made her feel a little bit too vulnerable and nervous about looking stupid. And they then sort of suggested that maybe a more intimate social media, a messaging group would have been helpful, where they could just connect on a sort of more intimate level and share their experience of the intervention. One did note that they would have maybe liked to met up over tea or coffee, prior to the intervention, which is interesting because this was something that was planned as part of the study, but of course COVID hit and we weren't able to do that. It really, I think, highlights the need for social and human connections, and supports the literature that talks about community being important for trauma healing. So just in conclusion, online group EMDR is an acceptable and feasible intervention for helping women to heal from breastfeeding trauma, and can tentatively be considered as preliminary evidence towards its safe and effective use by clinicians for treating women within this population. Thank you very much, and I'm happy to take any questions if there are any, Marlene.
Very much, Rachel. It's fascinating research, it really is, and we have asked if anybody could send us a question, so we're only going to take one question because of the time frame. I have a question from Margaret McLean, and she just wants to know, Rachel, could you just tell her what methodology you use for your qualitative analysis, please?
Yes, I used a thematic analysis. I used the Brown and Clark thematic analysis for my qualitative phase.
Thank you very much. We'll have to let it go there, Rachel. If I ask people if you could just put your questions into the question and answer box, and Rachel will hopefully be able to continue. You can see them, Rachel, and Rachel will respond to you if that's okay.
Yeah, no problem.
Thank you very much, Rachel. Now I need to just speak to you all again, just to remind you something that I promised my colleagues I would actually do, but I didn't do, so my sincere apologies. I promised my colleagues that I would ask all of you who joined us today to put your name in the chat box when you join, just to say hello, my name is such and such a person, and what country you're from. And just, what time of the day it is where you're at. So I'm just asking, it's a bit late, but if you don't mind, if you could just do that, because it's always nice to say hello, and we do like to see you. I mean, we can't put all the cameras on, it'll crash our system, but I do want you to know that we are conscious of the fact that you're there and you're listening, and you're very, very, very welcome. So thank you very much. We are at the stage now of our conference where we have our guest speaker, and the guest speaker today is, wow, there's so much that I could say about her. I mean, in terms of a midwifery giant, in terms of a research giant, in terms of a colleague and a friend, I mean, just a giant person in my life. I couldn't find enough words to describe Dame Professor Tina Lavender to you. I really couldn't. Her biography, I have to say a few little things too, because it's too important for me not to. Dame Tina is Professor of Maternal and Newborn Health, and she's the Director of the Centre for Childbirth and Women's and Newborn Health at the WHO Collaborating Centre, Liverpool School of Tropical Medicine. Dame Tina holds the Honorary Chair at the University of Manchester. I'm very proud to say, I'm delighted to say, that she's a visiting professor at Ulster University, and she's also at the University of Nairobi. Tina leads a programme of research with a focus on improving maternal and newborn outcomes. And she's also a director of the NIH Global Health Research Unit on prevention and management of stillbirth and neonatal death, involving 8 countries. She's the associate editor of the African Journal of Midwifery and Women's Health. Tina has done amazing work in Africa, amazing educational and research work, developmental work. And Dame Tina is an honorary fellow of the Royal College of Midwives, and she also acts as a regular advisor to the World Health Organization, particularly in relation to research priority setting, guideline development, and she's a reviewer of educational materials for them. Do you remember that when you're looking at some of those WHO materials that we all regularly access? And in 2016, Tina was nominated as one of BBC's 100 most inspirational women in the world, and she truly deserves that. Believe me, she truly deserves that. And in 2018, she was made a senior NIHR investigator. It's wonderful to have you here, Tina. I'm delighted that you can spend time with us today and that you're here in person. Over to you.
Thank you, Marlene, and thank you for those very kind words. I'm not sure that that's me, sometimes a bit of imposter syndrome, but thank you very much. And thank you for inviting me to give a keynote presentation for the second time, which means that hopefully I wasn't too bad the first time because you've had me back again. And I just want to also just thank all the previous speakers who are doing some absolutely amazing work and really set the tone for my own presentation on the challenges and opportunities in breastfeeding research. So within my presentation, I'm going to ask more questions than provide answers. And the questions which I'm going to ask are, do we actually need breastfeeding research? What evidence currently exists? What are the gaps in that evidence? Why aren't the gaps filled? Or indeed, should we be filling those gaps? And what are the research opportunities? So if we start off with this question, do we need breastfeeding research? And I'm making the assumption, the fact that there's 170 participants on this call, that maybe you all feel, yes, we do need breastfeeding research. But often I've had conversations with individuals, both health professionals and non-health professionals, saying that breastfeeding research is not necessary because breastfeeding is natural. And we all know that mantra, don't we, of breastfeeding is natural. I think there are some very good papers out there that tell us that breastfeeding is natural, but it's not always the cultural norm, which means that it doesn't actually happen. So maybe we do need breastfeeding research, despite the fact that it's natural. Also, this paper is a really good paper which talks about breastfeeding is natural, but it's not always easy. So again, maybe people need support in order to do the breastfeeding, and maybe that's where research comes in. Or perhaps we should stop talking about what is natural. And the promotion of breastfeeding as natural is actually very unhelpful. It's potentially harmful, and it's really not evidence-based. So we should no longer be saying breastfeeding is natural. And just to continue with this train of thought, breathing is natural because we do it automatically. But walking is also considered natural, but we have to learn how to do it. And I think that if breastfeeding fits more into this box than the breathing box. And if we think about breastfeeding, people require individual support. They need instruction. They need patience. They need to be able to know the techniques and to practice how to use those techniques. They need consistent messages, positive reinforcement, and importantly, opportunities to fall down and get back up again. So this is very much similar to walking. All these things are needed in order for women to be able to breastfeed. So maybe breastfeeding is natural, but it's a natural attribute that needs to be learned. We need to think of a better terminology. So as Marlene said, I work globally. Most of my work is actually in sub-Saharan Africa. So I observe breastfeeding when I'm over there doing my field work. And if we look at the breastfeeding rates, they can be encouraging. So if we look at the top left graph, any breastfeeding at age 6 months, and we look according to income groups. So we see the high income, the upper middle income, the lower middle income, and the low income. And they're indicated by the lines. And you can see in the low income, the rates are fairly stable and high. So that's any breastfeeding at 6 months. You can see even the high income countries in the green bar, they're not as impressive as the low income, but they are rising. And then we can look at the lower, looking at the world regions, and we can look at the rates there. And again, we see that some of the areas like Western and Central Africa are pretty consistent and very high. And we can look at Western Europe, which is the lowest bar, the light blue bar, and not as impressive, but again, it seems to be on the rise. And then the two charts on the right, they're looking at the same things according to age 1 year, which we would expect would be slightly lower rates. So why is that difference between the different income groups? And why is it that difference between the world regions? And just to show you a little bit more of the evidence globally, this is exclusive breastfeeding. So whereas the previous one was any breastfeeding. So we see that these rates are not quite as impressive. And we only have the longitudinal data here for the income groups of upper middle income, lower middle income, and low income. And you can see that they're not quite as impressive. So on the left-hand side, we have the income group, exclusive breastfeeding, and the lower charts, again, are looking at the world regions. And you see that the global target of 70% exclusive breastfeeding by 2030 is quite a long way away. So how do we reach that target? Because these graphs show us that our current trajectory is not really going to meet them. So is that why we need to do breastfeeding research? And we learned from the recent Lancet breastfeeding series, which I urge people to read if you haven't already done so. It only came out this year, over the last couple of months. And what they tell us is that globally, only 1 in 2 newborns are put to the breast within the first hour of being born. And we've been discussing this for a long, long time and trying to promote it, both in the UK and overseas. You know, all the countries have been promoting this, but it's clearly not happening from the latest evidence. And obviously, whatever we do in health or in research, we have to look at the costs and the value. And with breastfeeding, and what we're told, again in the Lancet breastfeeding series, is that approximately $341 billion per year is lost from unrealized benefits to health and human development. So just think about that for a minute. That is huge, isn't it? And this is due to inadequate investment in protecting, promoting, and supporting breastfeeding. So this means that something really needs to be done about it. If we look a little bit closer to home as well, and if we look at England, which is obviously where I work, we know that 76% of all babies have had formula milk by 6 weeks. And the cost to the NHS every year of treating just 5 of the illnesses linked to babies not being breastfed is at least 48 million. And you can see here listed the diseases that they've looked at in terms of doing the cost analysis. So that's ear infection, chest infection, gut infection, necrotizing enterocolitis, and breast cancer. And there are other diseases as well. So from this, what it tells us is that we could save an awful lot of money, as well as the obvious impact in terms of the suffering for those individuals if we could promote breastfeeding. So is this another reason why we should be doing research? So we don't want to just look at the economics related to breastfeeding, we want to look at other cost benefits. So improved health and development for children, improved health for women, and also we know that it improves cognitive development, learning and educational attainment, productivity, wages, and the overall economy. So breastfeeding is really, really important. But it clearly isn't happening to the degree that it should be globally. And as I said previously, I work a lot in low and low middle income countries. And we know that 1 in 3 babies in low middle income countries are given fluids other than breast milk during the first 3 days of life, and increasing the risk of breastfeeding failure. And one of the countries that I'm working in is Malawi, and they tell me that their figures are actually reducing quite rapidly, and breastfeeding is beginning to fail when it has been consistent for a really long time. And that would be terrible if some of the low middle income countries started practicing in the way that we've been practicing, rather than them being able to encourage the populations in high income countries to breastfeed more successfully. So if we move on a little bit and say what evidence actually exists, and the first thing we always do is go to Cochrane to see, well, what are the reviews that have been conducted that have looked at the many questions related to breastfeeding. I'm just going to share a few of those with you, just to point out some of the factors that could help us in moving forward with the breastfeeding research agenda. So this review is about antenatal breastfeeding education for increasing breastfeeding duration. And this was a review of 24 studies with data from almost 10,000 women. And this what they found was, compared with standard care, antenatal breastfeeding education makes little or no difference to the initiation of breastfeeding. And this was high certainty evidence. So this means that the studies were robust and they were in different geographical areas, and probably makes little or no difference to the proportion of women exclusively breastfeeding at 3 or 6 months. And the evidence there was moderate, so there is room for improvement. And it makes little or no difference to the proportion of women giving any breastfeeding at 6 months. Again, this was a high certainty of evidence. And this may be the same at the 3 months, although the evidence isn't as strong for that. And antenatal breastfeeding education then probably makes little or no difference to breastfeeding complications as well. So that's moderate certainty evidence. So we know that there's been multiple antenatal breastfeeding educations, but clearly it is not always working. Another one is interventions for promoting the initiation of breastfeeding. And this was a review of 28 studies with more than 100,000 women. And what was found was that breastfeeding education and support, either led by a healthcare professional or a non-healthcare professional, may improve the rate of women starting to breastfeed. But it was low certainty of evidence, meaning that there is room for improvements in the research that's carried out. Effects on the rate of women starting to breastfeed early, i.e. within an hour after birth, are uncertain. So again, there's room for further research here. And there's not enough information available about the possible harms of interventions for promoting the initiation of breastfeeding. So let's look at early skin-to-skin contact, which we all promote quite a lot. And there's 46 studies included in the review with 3,500 mothers and their babies. And this was from 35 weeks to full term. What we found from the accumulated evidence is that early skin-to-skin contact probably increases the number of women breastfeeding at 1 to 4 months with a moderate certainty of evidence, and probably increases the number of exclusive breastfeeding up to 6 months. At birth, babies held in skin-to-skin contact may be better stabilised and have higher blood glucose levels, but similar temperatures to those who are receiving standard care. And again, there's not enough information available about the possible harms of skin-to-skin contact. And that's actually a thread throughout all these Cochrane reviews, that people don't collect enough information about any potential harms. So cup feeding versus other forms of supplemental enteral feeding. This was 5 studies with almost 1,000 newborns. Most of them were preterm, and it found that newborn infants unable to fully breastfeed may be more likely to be exclusively breastfeeding at hospital discharge when they have supplemental feeds by cup rather than by bottle. And this was low certainty of evidence. And whether newborns are cup or bottle fed may make little or no difference to weight gain, and the effects on length of hospital stay or breastfeeding rates at 6 months are uncertain. So the evidence isn't strong there. And again, no information on harm of the different types of feeding. And here's another one that is sometimes controversial, and this is about pacifiers or dummies, that we would call them. And this was only 3 studies included with 1,300 full-term infants. And it found that whether infants' use of a pacifier is restricted or unrestricted probably makes little or no difference to the proportion of infants exclusively breastfeeding at 4 months of age. And there's not enough information about the effects of pacifier use on the duration of exclusive breastfeeding, maternal satisfaction and confidence in parenting. And again, there's not enough information about the possible harms of the pacifier, such as breastfeeding difficulties or the effects on the infant's health. And then painful nipples that we've already heard about today. The Cochrane review with only 4 studies with a minimal number of breastfeeding women, less than 1,000, found that in breastfeeding women with painful nipples, applying various treatments, and we all know what those treatments are, so I won't read them out. So for most women, regardless of treatment used, there's little or no important difference to nipple pain. Here the Cochrane say that pain may reduce to a milder level between 7 to 10 days, but this is low certainty evidence, and we've already heard that nipple pain can continue up to 8 weeks. And again, not enough information about the possible harms of interventions for painful nipples. Rooming in for new mothers and infants versus separate care. This is also another controversial review, and this only included 1 study with less than 200 women. And what it found was that keeping mothers and infants together in the same room after birth until discharge from hospital may increase the rate of exclusive breastfeeding 4 days after birth, but may make little or no difference to the proportion of infants breastfeeding at 6 months. But here there's a real evidence gap, and there's not enough information on the effects of rooming in on the duration of breastfeeding, frequency of breastfeeding, or maternal level of confidence in breastfeeding. So this is an area that needs further research. And there's not enough information about the possible harms of rooming in versus separate care. And then treatment for breast abscesses in breastfeeding women. This is another area where there's a clear evidence gap. There were 6 studies with data only included from 4 of those studies, with only 325 breastfeeding women with abscesses. And from the findings, it was established that it's uncertain whether breastfeeding women who have developed a breast abscess are more likely to continue to breastfeed if treated with needle aspiration or with incision and drainage. And it's also uncertain whether abscesses heal more quickly with one approach or the other. So this is an area that really does warrant further research. There are many more Cochrane reviews, and I'm not going to go through them all. I just gave you a sample. There's reviews on baby-led compared with scheduled breastfeeding for successful breastfeeding, supplementation with multiple micronutrients for breastfeeding women for improving outcomes for the mother and baby, and methods of milk expression for lactating women, and multiple reviews related to preterm babies, many reviews. And what is common about the majority of these is that there's not enough information available to say with high certainty that this evidence should lead to those recommendations. I think we also have to remember when we're looking at Cochrane evidence that this is mainly randomised controlled trials or quasi-experiments, and that might not always be the right methodology in order to establish important findings related to a topic such as breastfeeding, which is a complex intervention in its own right. So if we look at the WHO recommendations on positive postnatal experience, they only really make 2 thematic recommendations, which is about exclusive breastfeeding and promoting, protecting, supporting breastfeeding facilities, providing maternity and newborn services. So WHO can only make recommendations when there is clear evidence of effect. So the recommendations are, as we know, that all babies should be exclusively breastfed from birth until 6 months of age. And they say that mothers should be counselled and provided with support for exclusive breastfeeding at each postnatal contact. But what that support actually looks like is still open for debate, because the research is really not strong enough at the moment. The other recommendations is that facilities providing maternity and newborn services should have a clearly written breastfeeding policy that is routinely communicated to staff and parents. And I'm pretty sure that most facilities don't do that. They might have the policies, but I'm sure that there isn't routine communication to staff and parents, certainly many of the facilities that I do my research in. And also health facility staff who provide infant feeding services, including breastfeeding support, should have sufficient knowledge, competence and skills to support women to breastfeed. And I would say that many health professionals do have those skills, but I wonder whether all of those health professionals do have the skills to support women. And maybe that's an area that we could perhaps do a little bit more on. And when we hear some of the qualitative narratives about women's experience, I would suggest that retraining, mandatory retraining is really important, so that people can refresh on their skills, knowledge and understanding of breastfeeding. So WHO in their postnatal guidelines, they only actually made one research recommendation, and it was a very specific one, which you can see here. What is the efficacy of neonatal vitamin D supplementation on mortality, morbidity, growth and development, including clinically relevant outcomes, assessment of vitamin D status and cost effectiveness of this intervention in breastfeeding and non-breastfed infants. So why did they only make this one recommendation? Well, partly because the evidence is not there. And also breastfeeding as a subject area is quite complex in that it cross-cuts many things. So it will be integral to other reviews, other guidelines, but on its own, the evidence to inform research recommendations is fairly limited. So what are the evidence gaps then? Well, maybe we need to look at the best way to implement WHO recommendations. We know that often WHO makes recommendations, but how does it get from their manual into the clinical space or into the community? And I think that's a big issue. I also think that we need to do a lot more in terms of incorporating socio-cultural beliefs and contexts. And this model here by Primo and Brando, I think is really important. Breastfeeding, as I keep saying, is a complex intervention, and it needs to be looked at from multiple layers, with the woman at the centre of that. It's about dynamic interactions. It's about the mother-child relationship and also the wider family. It's about society, roles, woman's body image, organisations, the cost effectiveness. There's so many different issues that it can't be looked at in a singular way. And I think that we know the benefits of breastfeeding. We know what needs to happen, but how do we make it happen? And sometimes I wonder, are we being too reductionist by looking at specific interventions rather than looking at breastfeeding as a whole? So why aren't the evidence gaps filled? Well, I think that one of the challenges is obtaining funding for breastfeeding research. I think because it cross-cuts, it's not always seen as important in isolation. It's sometimes not seen as a priority because it's something that women do, and also because it doesn't do harm. Often when you put in a research grant, it gets funding because you're trying to minimise harm. So that's one of the issues. So I think that pinning on the cost effectiveness might be a way to get funders to actually change their mindset and fund more research into breastfeeding. I think breastfeeding research is costly to do as well. It's costly because of the measurements, because of the longitudinal nature. So there are many reasons why breastfeeding research is challenging. It's also practically challenging as well. It's practically challenging because it's not an observable outcome. So we can't go and observe if the women are breastfeeding. We're very much reliant on women informing us of when they breastfeed, how long they breastfeed, whether they're exclusively breastfeeding. I know when I did my cluster randomised control trial quite a long time ago now, it was an absolute minefield. And also choosing the right measurement is also a challenge, which I'll talk about a little bit more in a minute. But when we did our cluster randomised controlled trial, which compared antenatal support groups to encourage women to breastfeed, we were looking at what should our primary outcome measure be. And we were looking at, the WHO recommendations, 6 months exclusive breastfeeding, etc. And we discussed with lots of the local women who said, no, we don't want that as our primary outcome measure. If I say that I want to breastfeed for 6 weeks and I succeed, well, then that should be the outcome measure. So what we actually did in the end was our primary outcome measure was whether women fulfilled their own expectations of breastfeeding. And in many ways, that took the pressure off those individual women. And some of them had expectations that they might breastfeed, say, for 2 months. But in actual fact, because they didn't have the pressure on them, they actually breastfed for a lot longer. So we need to make sure that our outcome measures that we choose are really meaningful to women who are breastfeeding. Breastfeeding is a complex intervention, and it's influenced by multiple physical, social, cultural, and psychological factors. And therefore, it's really hard to look at a single intervention to improve breastfeeding rates. So that makes it a lot more complex to do research. We know that there are many methodologically limited studies. So this is one of the reasons why the gaps aren't filled. A lot of studies are underpowered, therefore they don't have enough participants to make any definitive recommendations. Often they're in single settings, so the findings are not transferable. So we need to be able to do better breastfeeding research that's robust, meaningful, and transcends many different backgrounds, both geographical and cultural. We need consistency in our measurements and follow-up. I think that is really, really important, and I'll come to that again in a second. And we know from the existing evidence that there's been few economic evaluations of interventions to improve breastfeeding rates. So if we do any research going forward, particularly if it has intervention, we need to make sure that we also have a cost analysis embedded within that. So if we move to the research opportunities, and I've talked about the inconsistencies in measurements, I really do think that there's a need to develop a core outcome set for breastfeeding research. For those of you who are less familiar with what a core outcome set is, it's a robust process that we go through to determine what outcomes should all trials capture as a core set in order to have consistency across studies and to allow systematic reviews and pooling of the findings possible to give us better findings, more robust findings, and better transferability or generalizability. So there hasn't been a core outcome set developed in the area of breastfeeding yet. There was one that was registered on the COMET website. The COMET website is a repository, a little bit like Cochrane, but it's for core outcome sets. So it was withdrawn in 2018, and there hasn't been another one registered. So this is certainly an area for investigation. Systematic reviews, we know, on breastfeeding intervention consistently report that study endpoints in the available trials vary widely, and it really does make it impossible for us to pool the data in a meaningful way. And I think by showing you those Cochrane reviews, you can see the results and why they're not as strong as maybe they could be. So this is something that desperately needs to be done, and if anybody wants to know a little bit more about this, then please do get in touch with me, and it's something that we could perhaps take forward. Also, I think another research opportunity is drawing on other case studies. So we know from the World Population Review, which was done this year, that there are some countries that are doing really, really well in breastfeeding rates. So in Croatia, 98% breastfeeding, in Rwanda, Chile and Burundi, 80%, or more than 80% actually. So why aren't we learning from these places? And even if you look across the UK, I just picked out some random rates. In Lewisham, we have 78.9% of people initiating breastfeeding, whereas in North East Lincolnshire, we have 28.7%. And even drilling down a bit more and looking at my own region in the Northwest, the rates are not very good across the Northwest, but in Manchester, 57.3%. Whereas in Halton, it's only 20.9%. So why can't we start learning from each other? And there could be a research opportunity there. I also think that we need to consider our research more holistically. So we need to consider research that encourages advocacy, systems, societal and individual level interventions, because single interventions on their own are not going to have an impact. And I love this picture here of the elephant. And what this is saying is if we look too closely at a specific thing, then we miss the bigger picture. So if you look at part of it, we might be misguided. We need to look as a whole. And also we need to be thinking about what research can we do that bridges the gap between awareness of benefits of breastfeeding and actual practice. So in conclusion, I've put this title here, Is It Too Late? Well, I don't think it is too late to do some really good breastfeeding research that has impact. I think we need to convince the funders of the potential benefits. We need to work more together to conduct research that makes real system changes and even societal changes as well. So we need more collaboration. We need to have active stakeholder engagement, and that's critical to move forward. And we also need to be very sensitive to those who are unable to breastfeed. And I think one of the most important points of all is we need to listen to what it is that mothers want. I think we need to ask women, if we were doing research, what would be the critical things that you would want to happen in order to give support. So I think that's really important. So finally, just to say that, I'm not telling you it's going to be easy. I'm telling you it's worth it. And I do think we can do so much more in the breastfeeding research space. And I look forward to hearing about future research studies and also potential collaborations with those of you that are out there listening. So thank you very much.
Wonderful. Oh, Tina, wow. I wish we could bottle you and we could keep you. You're unbelievable. I mean, what a really great presentation of the research evidence with your insight from your multiple roles in terms of the World Health Organization, in terms of your role in Cochrane, in terms of your role as a researcher. I mean, the timing of this is perfect for us for the future, because we are at a point here in Northern Ireland where we are trying to make decisions about the next steps in terms of breastfeeding research. So I know I mentioned to you about calling upon you to be working with us in relation to the workshop that we're planning, and we'll be in touch with you shortly after this event. And thank you very much for being here, and thank you very much for agreeing to help us. And delighted. And I mean, when I think about, there's so many research questions, you have given us so many ideas. You have provided an excellent presentation. And I've got some super questions, but I'm going to only take, because of the time frame, I'll take two of them. There's a question here in relation to cost, wanting to know why it closed. Why was the cost withdrawn?
I absolutely don't know the answer to that, so sorry about that. But I do know one of the people who were part of the group. It was an international group who had put it forward. I imagine that, cost takes a lot of money and time. So I don't know whether it was a funding issue, but I do plan on contacting one of the professors who's part of that group to get a little bit more insight into that. But I imagine it would probably be because of funding. The most valuable costs are done globally, and they require probably a couple of years of funding in order to, first of all, review all the outcomes that are in the literature. And then to do the prioritization exercise in order to decide which ones should be included. And there's several steps to those processes. Therefore, it could be that, I'm guessing, but I am going to confirm with the group why, because I do think it's something that somebody really needs to pick up.
That's very helpful. Thank you very much. The one other question that we will take is in relation to somebody's asked us about cannabis, asking if we know any research has been undertaken in relation to the cannabis, to the effects of cannabis that it may be taken intermittently, and are there any policies or any guidance on it? So it's a new one for me too. So if you can help us with that, that would be appreciated.
Yeah, no, what a really interesting question. So thank you.
Isn't it?
Yeah, but I'm not sure I know the answer.
I don't know the answer to that either.
I haven't seen any evidence. I imagine if there is any evidence out there, it will not be very robust, because it certainly hasn't come up in any of the Cochrane evidence I've seen. I think it would be a challenging study to do as well. And I can't imagine there'd be much funding for it. So my answer is I haven't seen anything. But yeah, I'm going to have a look after this though, just to see.
Can I be so bold? I'm taking liberty here by asking you a direct question, so please forgive me. In terms of the harms, Tina, when you mentioned the harms, I must say now my ears were pricked up when I was thinking about these harms that you're talking about. And you must have mentioned that we needed to be looking at the harms caused by some of the interventions or some of the, and it made me think, it's something that we don't always like to look at, harms. I mean, I know I personally spoken several times about pollutants and transferring to breast milk and build up and infants, and it hasn't gone down too well. But I mean, I just know that, we shouldn't really be afraid of looking at harms. We should identify them, address them, and get on with the job. So, I mean, I've been very interested, if you didn't mind, I'd really like to hear your thoughts on the harms.
Yeah, I think it's a really important thing. I think that we shouldn't really go into any studies without being in equipoise to start off with. So that means we need to look at the benefits and the harms. We can't go into a study on breastfeeding because we want to prove that it's actually, there's something that's going to work. There's something that's going to work. I mean, I could give a whole new presentation on equipoise, but I think that that's what we need to consider. So, and sometimes looking for the evidence on harms and not finding any harm is stronger than looking at the benefits and finding the benefits in certain subject areas. So to have the complete picture for any research we do, if it's looking at interventions, then we do need to look at the harms as well as the benefits.
Thank you very much. I'm going to have to let you go, but before you go, there's one thing I wanted to say to you. I was wondering, you remember many years ago, Tina, we did fantastic research in Northern Ireland that was funded. Janine Stockdale's research. Janine's now working over in Queen's University, and wonderful. She's got senior lectureship over there. But we did really, we talked to you about that research because at the time we were looking exactly at what that, the terms of, looking at your primary outcome was looking indeed at the motivation that women had and setting their own breastfeeding goals. So it's almost like, takes 15 years sometimes, I think, but still takes 15 years. Sometimes that research needs to be resurrected. So if Janine, you're listening, I hope that you're over there in QUB thinking about picking up that research, and just remember, we're still over here. We're always willing to work together collaboratively. Thank you very much, Tina, Professor Dame Tina. Thank you very much. Wonderful presentation. And there are plenty of comments in the box from individuals again saying thank you very much. Fabulous. You made it fantastic. Thank you. And now, folks, we're on to our last, but by no means least, we're presenter for today. And our next presenter is a mummy of 3 beautiful children, and she is also a nutritionist, and her name is Dr. Mary Jane McCluggage. And Mary Jane is going to be talking to us about her breastfeeding journey. And Mary Jane, you're very welcome, and it's so lovely to have you speaking as a mummy and sharing your experience with us today. You're very, very welcome. And Mary Jane, is there anything else about your 14 years of experience in women's health? Yes, and you do a lovely wee blog. Mary Jane also works on a freelance basis, writing evidence-based nutrition articles for the general public. Lovely, wonderful. Mary Jane, over to you. Enjoy. Thank you.
Thank you, Marlene. Thank you. Hi everyone, thank you so much for having me here today, and thank you, Marlene, for inviting me to share about my breastfeeding journey. As Marlene said, I am a registered dietitian. I work part-time in the NHS, and I do a bit of freelance as well. But I am currently on maternity leave with my 3rd baby. So it's been a long time since I've done something like that. So yeah, I have a research background. Most of my research has focused on women's health and in particular antenatal care. And to this day, I'm still very passionate about wanting to work to improve the health of the population and women in particular. I live with my husband, Alan. I have 3 daughters, Isla, who is 5, Ruby, who's 3, and Maddie, who's just 7 months old. At any conference that I've spoken at before, I've been sharing about other women's experiences. I've been talking about the data as such. So today I am speaking from a much more personal perspective, focusing on my own experiences as a breastfeeding mother. I'm going to talk about the challenges that I faced and the factors that kept me going through those difficult times. And then at the end, I will share a few research questions based on my own personal experience. with that in mind, it's obviously important to say that it is a privilege to share my own personal experience. And in many ways, I feel vulnerable doing that, but my breastfeeding journey obviously is in no way reflective of the entire breastfeeding population, although I'm sure some of the things that I'm going to talk about that I have experienced will resonate with other breastfeeding mums. I have been very fortunate to be able to breastfeed all 3 of my babies, and I do not take it for granted because I know it is very difficult for many women. I've breastfed them for various lengths of time and with very different challenges. So I'm going to begin today just by sharing my breastfeeding journey by taking you back to 2017 when I first became a mum. So next slide. I knew from the moment that I found out that I was pregnant that I wanted to breastfeed my baby. As I had already mentioned, I spent all of my education and working career up until that point trying to improve people's health. And part of my job was actually to encourage women to breastfeed. So of course, I was aware of all the wonderful benefits of breastfeeding for both my baby and for me. And my motivation for breastfeeding was very high. So I did make it my aim to try and prepare myself as much as possible during that antenatal period. So I did attend the breastfeeding workshop that was offered to me by my community midwife. I talked to other mums who had breastfed. I read articles. I remember looking up video clips on YouTube about latching, about all the nipple cream, the nursing bras, the silver cups. I felt pretty prepared for breastfeeding. Next slide. So the reality hit me like a ton of bricks. It was just, for some reason, I didn't hear about the nights of cluster feeding until the community midwife came out after birth. And when my baby fed all night long, I started to wonder, was there something wrong? Why was my baby not wanting to be set down? I was told that if there was any pain or discomfort, then the latch was wrong. And so with every feed, I felt really unsure about my latch. During my time in hospital, I hit that buzzer at almost every feed to see if my latch was okay. And that was in the advice of someone else. I'm sure the midwives maybe weren't too pleased, but actually they were very gracious and they were very patient with me and actually did give me time. And I know that that might even be different now because hospitals are so busy and staff are so rushed off their feet that there maybe just isn't that time in hospital to help women with their latch. Some of the challenges that I faced in those first few weeks and months were nipple pain, a tongue tie, mastitis, and just a feeling of overwhelm and just pure exhaustion. I didn't prepare for breastfeeding to be that hard. And as time went on, it did get easier, but I struggled with other things. I had a bottle refuser. I had comments from well-meaning friends and family, things like, you know, she's very attached to you, isn't she? Would it not be better just move her onto bottles? It would make your life much easier. I remember the advice to me was to leave my baby for long enough and she'd be hungry enough to take a bottle. And actually that really didn't end very well for us. The stress of going back to work with a baby who doesn't take a bottle is real. And the stress that, you know, is put on women to continue to live these independent lives apart from their baby. It doesn't facilitate for breastfeeding. Sometimes, if I'm completely honest and raw about it, I looked at my bottle feeding peers and I thought, why am I putting myself through this? I don't feel at times that our culture is made for breastfeeding mums. I don't think that we have the support in the village that we used to have for mothers in general. And I think expectations on mothers are unrealistic. Expectations on our babies to be independent from a very young age, I feel, is unrealistic. And I think all of these things can make breastfeeding really difficult, especially as an inexperienced mum. Next slide. Thankfully, I had a really good community midwife who caught the tongue tie early. who sent me out a lovely lady from the trust who was able to check my latch and to give me support. Almost immediately, I joined the Breastfeeding Northern Ireland Facebook page that Adele had spoken about before earlier today. And this was an excellent source of peer support for me, and I found being in that group really helpful. I did have breastfeeding friends, which I don't take for granted, who went through similar struggles as I did, and having that was really invaluable. I was also directed to good evidence-based resources, which helped. I also had a very supportive husband, mum and mother-in-law, which I have no doubt contributed to me being able to persevere through the difficult challenges of breastfeeding. It did get easier and it was so worth it in the end. And I did manage to breastfeed my first baby for over a year. Next slide. I still can't help but wonder, would I have handled these challenges better if I had been more prepared for them during the antenatal period? Do we really prepare women for the challenges that they're going to face? I know Tina touched on this a bit in her presentation about the whole idea of breastfeeding being natural, and what that insinuates is that it's going to be easy and your baby's just going to latch on, and if it's natural, it's going to work, and that's not really what women experience. Do we prepare women that their babies are going to feed all night for the first couple of nights until the milk comes in, that the discomfort and the pain can ease in time, and it's normal for your baby to need you so much? And I found this little campaign poster from an NHS trust in Scotland, and I thought it was very good, that breastfeeding is a skill and it takes some practice. Next slide. Baby number 2 was a very different experience. I will never forget the words of the consultant at our 20-week scan when he said to me, there's a high probability that your baby will not be compatible with life. And that really floored me. After a major heart anomaly was detected, and they had also queried some nuchal thickening behind the back of the neck, a referral to fetal medicine was made. After further investigations, our baby was diagnosed with TGA, transposition of the great arteries. This is a birth defect of the heart in which the 2 main arteries are switched and they're in the wrong position. Everything changed from that point. My care was transferred to fetal cardiology in the Royal, and plans were made for me to give birth in Dublin, as my baby would likely be critical once born. The only way to save her life was to undergo corrective surgery to switch the arteries back into the correct position. I can remember the specialist nurse telling me that breastfeeding was still possible, but that it may be much harder and that many cardiac babies struggle to breastfeed. Despite that, she was incredibly encouraging, and they did their best to try and prepare me to breastfeed, as she knew that it was something that I really wanted to do. I remember reading some literature that was given to me that said the actual work of breastfeeding is actually less than the work of bottle feeding for these babies. The sucking, swallowing and breathing are actually easier for a baby to coordinate, and the amount of oxygen available to your baby is greater while breastfeeding. And actually, in general, when compared to bottle-fed babies, breastfed babies with congenital heart defects have more consistent weight gain, which encouraged me, but I found surprising, because I felt, and whether this is true or not, I felt that, you know, a lot of sick babies and cardiac babies did end up going on to bottle feeding. I had to grieve a lot of things that time around. That I wouldn't have the birth that I wanted, I would be away from home, that I wouldn't get to hold my baby or have that skin to skin before they were whisked away to a different hospital, and also that I might not get to breastfeed, something that was really important to me. Next slide. So to cut a long story short, our baby had corrective surgery at 3 days old and did better than we could have ever hoped or imagined. And she truly is our little miracle. She was transferred to Children's Health Ireland in Dublin to have her surgery. The support for breastfeeding there was above and beyond. They had breastfeeding champions in every ward. They had hospital grade breast pumps everywhere, very easily accessible. They had a pumping room that was private with a comfortable chair with tea and coffee making facilities. They had rooms full of milk storage containers and fridges for storing breast milk. They had pull-out beds beside each baby so that you could be close to them and sleep there overnight. They had free meals in the canteen for breastfeeding mums, and there was supportive literature everywhere, even on how to maximise pumping. So after almost a week of exclusively pumping and Ruby was fed via a feeding tube, I was encouraged to try and get Ruby to latch on. This wasn't easy. She was very tired, obviously, after her surgery, but the staff were really supportive, and they were happy to try and lift her to me, despite all the leads and the wires and the tubes, to allow me to have skin-to-skin contact with her. And I know that took time, and sometimes health professionals don't have that time, and with perseverance, she did have that feeding tube out and was exclusively breastfed before that we were transferred back to Belfast. I was very nervous, obviously, about being discharged and going home with a new baby who had been sick. I had a 2-year-old at home too. But I remember one of the midwives in Dublin saying to me, "Your one job is to feed your baby. Make sure your husband makes you lunch every day, that you can store in the fridge and eat with one hand. And don't worry if your toddler has to watch more TV than you'd like. Just take all the help you can get and focus on feeding. And in time, it'll get easier and it'll get less intense." And for some reason, I will always remember that conversation with her. Something so simple, but it just really took the pressure off me and really encouraged me. On transfer back to Belfast, I was greeted again with a lovely supportive team. However, facilities were lacking. The breast pumps weren't on the ward when I arrived, and they had to be sourced from outside. The wards were smaller. There was nowhere for me to sleep on the ward. The only option was to sit on an upright chair. And after a difficult birth and how exhausted I felt, I just knew I couldn't sit on a chair all night. I didn't want to jeopardize breastfeeding by going home. If I did go home, the options were for Ruby to be fed via a bottle or for the feeding tube to be passed again. I'd worked very hard to establish breastfeeding. This felt like a barrier to me. I just wanted to get home to my 2-year-old, and I knew that if feeding wasn't established and going well, then I wasn't going to get home anytime soon. In this moment, it was actually my husband who advocated for me. When I felt too drained emotionally or physically to fight these barriers, he was the one who challenged them, which actually shows you how important it is to have supportive family and partners. And in the end, the nurses were so supportive and so kind, and they accommodated me by setting me up in a camp bed in a room off the ward where the patient leaflets were. And then they just came and got me through the night when Ruby needed fed. And a breastfeeding support worker visited me the next morning, and she offered me support before we were discharged. And I ended up feeding Ruby for 9 months, which was great. Next slide. So I'm now in the middle of my 3rd breastfeeding journey with little Maddie, who's 7 months old, and she has been exclusively breastfed up until this point. And we've still had our challenges, the pain, we've had a bout of mastitis, we've had the cluster feeding, we've had the exhaustion, I have another bottle refuser. However, I can say this time it's actually been a real joy. And thinking about why this is so different than the previous times, and a massive factor in that is the value of my experience. Those previous experiences have prepared me for the challenges of breastfeeding. I wasn't shocked when I encountered problems. I knew it was normal to struggle. I was better prepared, and that I knew what to do and where to turn when problems came up. And finally, I knew it was worth it for that bond you have with your baby, and for how easy it is once it worked out. Next slide. So just on the back of my own experience, I just thought that these were a few possible questions that I felt could be addressed and are and have been addressed by breastfeeding research that's going on in Northern Ireland and around the world. But for me, it was preparing women for the challenges of breastfeeding, increasing their confidence and motivation to continue breastfeeding despite those challenges. And how do we influence culture in relation to realistic expectations around breastfeeding? I have missed out on a lot of things in our culture because my babies didn't take bottles, and it's trying to make that okay. And how can we support women with sick babies to breastfeed? How can we establish the resources to allow them to do that? So I'm aware it's just after 12, but thank you for listening to my experience and for allowing me to share that with you all. Thank you.
Wow, Mary Jane, thank you so much, and thank you to your husband, and thank you to your 3 beautiful daughters. Thank you for coming here today. I mean, you know, we kept you to the end, and you know what they say, you know, you save the best to the end, because at the end of the day, no matter how great we are as researchers, you know, we can all sit in our ivory towers and do things, but really at the end of the day, this is about the human experience. This is about telling the truth, about telling it from your gut. And you know, what you have shared with us today is it's invaluable, and thank you so much for doing that. And I'm sure it wasn't easy for you to go back and remember some of the experience. I mean, Ruby is a blessing, and it's so lovely that she's done so well. And if you were here last year, we Joanna Perley and myself have been doing research. We worked with Dr. Maria Lone and the team. We've been doing research. We looked at the breastfeeding in relation to women who'd actually had babies born with different congenital anomalies, and you know, so what you were talking about, you know, is so real, and you know, and your illustration of the journey is so valuable to this Doctoral Midwifery Research Society, and I hope that you'll allow us to keep that video up, because it will be helpful to other mothers. You know, there's so much that you've shared, you know, the whole preparation, the expectation, the reality, you know, your search for evidence, your support online, your support from family, your support, you know, and wonderful support from staff too in the institution, and the services that are available. All these wee small things which are so important. I mean, even having the pumps, having those things normally around you, you know. I mean, it's so lovely to hear what you've had to say. And people are really, they're all coming on. You can see in the chat box, everybody's sending similar comments of deep appreciation for what you've done for us today. So I on behalf of everybody, thank you very much. Thank you, dear Lord, for sending her to us today. Thank you, Jane, tell your husband I said thanks a million, and thank you to Mummy or Granny, whoever's looking after the little ones for you. Thank you very much.
Thank you.
In terms of questions, oh, just in the question and answer box. Let me just check now. Leah might have sent me a question or two. Oh, I don't see any actual questions. I see what we've got in the box, Mary Jane, are wonderful comments of gratefulness to you. So thank you very much. I don't see the questions, but we'll if that's okay. If anybody has any other questions, then they may submit them afterwards. So people, we've come to the end of what I can only say has been, I hope, for you, a really beautiful walk through some of the breastfeeding research, some of the breastfeeding support, some of the breastfeeding experience, some of the breastfeeding education, knowledge, the research. You know, what you've had today, I hope, has been a spotlight on some of the breastfeeding research that we have tried to do here in Northern Ireland, in the Maternal Fetal and Infant Research Centre at Ulster, in the Doctoral Midwifery Research Society, in the Breastfeeding Implementation Strategy Group, you know, in Queen's University, Ulster University. We have tried, and we will continue to try, to make our little contribution to this terribly important research area. And with Professor Tina's support, we will continue this on and try to engage in multi-professional, I hope it may be multi-site research, but certainly we will be working towards that in the future. So watch the spot, and hopefully there will be more research to share with you next year. It comes to me just to say thank you now. I did say thank you to everybody at the very beginning, but just in case some of you weren't there, This event wouldn't have happened without lots of people. It wouldn't have happened without people in the background. And, you know, there are so many people in the background, and I hope I don't forget any of them. But the first thing is to thank Dean Professor Tina Lavender for giving us her expertise, her vision, her knowledge, and sharing her time with us. Thank you so very much. And thank you to Mary Jane. Thank you so much, Mary Jane, for all that you've done today. And Adele Payton, thank you for the work that you have done, for the women's lives that you have touched, for the research that you have supported, for your presence here today. You are also invaluable. Mary Jo, Sharon, and Rachel are PhD students and who are trying to do the best possible ever research that you can do. And they're trying to do it to the best, to the most rigorous research and challenging, and, you know, trying to, you know, to take down the barriers, trying to do outstanding research. Thank you all very much for sharing your research with us today. I really, really greatly appreciate it, and we wish you all the best for the completion of your research and for the dissemination of your research. And I think Rachel has put some of her publications maybe into the chat box, and maybe links to some of the outcomes. And I know that Mary Jo has done that as well, and that's really important. We thank you for that. I'd like to make special thanks to Dr. Joanna Perley from the Institute of Public Health. I mean, she has been on the end of the phone and on the chat box. I mean, your support to me has been incredible. Thank you very, very much. And by your side, Dr. Nicola Armstrong, our friend and program manager at the HSE. I can never remember the big long name, but so forgive me if I don't say it, Public Health Agency, or indeed Northern Ireland. And also then for Dr. Anita Yakunda, who's also been working with us in developing questions for the workshop, which will be following this event. We'll be in contact with you later and let you know about that. And certainly want to say thank you to the HSE Public Health Agency R&D, and also to my own Institute of Nursing and Institute of Nursing and Health Research at Ulster University, and a warm welcome and hello to the head of the Maternal and Infant Research Centre, Dr. Maria Lone, who's joined us today. Thank you, Maria, for your support as well. And from the Joanne Savage has been helping as well, and helped to get all the materials ready today. And also Adam, Leah, and Marissa, who are in behind in the dark, working continuously in the early hours of the morning and very late last night. And you have been just super. Thank you all very much. Thank you to you participants. Thank you to every person who has joined us from every part and every corner of the world. Thank you for being with us today. You have no idea how wonderful it is to be here, and the encouragement you've given me to keep going, because it's hard to keep going some days. So thank you very, very much. Take care. God bless all of you, and thank you. And hope to see you next time, around this time next year. Bye, everybody. Bye.